We encourage you to type your questions in the chat function throughout the webinar. You don't have to wait until the end. We will answer as many questions as we can at the end of the webinar. This is a good chance for us to hear your questions about this program, because your questions are very important to us. A brief overview of the agenda. So Dr. Wu will outline TennCare's overall opioid strategy. He will also review the buprenorphine MAT program description that each TennCare MCO will use for provider contracting. This is the review of the program description I sent to each person who registered for the webinar. If you did not receive a copy of the program description, please enter a comment in the chat function with your email address and I will get a copy to you. We will then hear from each TennCare MCO, Amerigroup, Blue Care, and United Healthcare about their contracting process. So with that, I'll turn it over to Dr. Wu.
Thanks, everyone, for making time out of your busy schedules to join in on the webinar. Certainly, this is an issue that is facing the country, but one that we here in Tennessee have also been trying to address in terms of the opioid epidemic. We're really grateful for the services that you provide to our members and to all Tennesseans, as well as the time and the effort you all take to provide the best care that you can and the partnership you offer to TennCare. Just a couple of level-setting terms and phrases to make sure we're all on the same page. I'm leaving this slide up for just a few seconds, but we know it can be acronym soup over here, and so we'll likely use several of them throughout the day, but some of the key ones we've outlined here. OUD is opioid use disorder. OBOT is the office-based opioid treatment, which is, as you all know, regulated by the Department of Mental Health and Substance Abuse Services, as well as some of the other common phrases. MCO we'll use a lot, which is Managed Care Organization. So let me dive right in, and just to kind of give a little bit of a high-level framing of where we are, why we're having this webinar, and what we hope will be a partnership that you all will join in with us as we continue to try to treat our TennCare members who struggle with chronic opioid addiction, chronic opioid misuse, and chronic opioid use disorder. As you all know, this is not surprising to you all. We, in the state of Tennessee, have for many years now been trying to tackle some of the unintended consequences and negative health outcomes that have been related to the growing use of opioids across the country, and particularly in Tennessee. And even though we've made some great strides on the prescription opioid front in terms of reducing the exposure and the amount of opioids that have been provided across the state, we still continue to see an increasing trend in several poor health outcomes, including members diagnosed with OUD. And this chart here is just to show, again, over the past 4 years, we've seen a tremendous growth of members being diagnosed with OUD. We understand this is just a small reflection of the larger landscape of individuals. And a second way to look at that information is in the last year, we've had about 24,000 unique members located across the state. This is the type of heat map we don't want to see. We wish there was a lot less red on this heat map, but just a way to kind of say that this is an issue that's touching all members across all of the state, across all of the regions, across all of our MCOs, and something that we have been looking at and working on and how to begin to tackle for many years, but have in the face of our current epidemic, TennCare really wanted to take another chance to look at it to see what there were opportunities or gaps that we could continue to increase. Certainly the last several years, the increasing evidence of MAT or medication-assisted therapy is certainly overwhelming, and one that we have paid close attention to and understand that there is a very real and important role in the treatment of addiction for opioid use disorder with MAT. The evidence is overwhelming. This is just one of several different studies we could have shown, but again, not only is it increasing the length of time of members in recovery, it is decreasing opioid overdose deaths, including with illicit opioids like heroin, and we know there's a lot of increased benefits on the criminal activity front, and as a whole, I think we are continuing to find ways to try to reduce the stigma around addiction, reduce the stigma around getting treatment for addiction, and trying to increase access to high-quality, evidence-based treatments such as medication-assisted therapy. And one of the reasons that we are having this webinar is really think about how we can do that systematically across the state. As part of a larger strategy, we have really focused in Tennessee and in TennCare specifically over the last year on 3 primary points of our strategy. The first one is really around primary prevention. The second is secondary prevention, and tertiary prevention as a third pillar, really a public health lens. If you aren't familiar so far in terms of primary prevention, we understand that for first-time and non-chronic opioid users, the medical evidence and the medical literature is very clear that the increased exposure, both in terms of dosage and in terms of length of exposure to opioids, drastically increases your risk of long-term opioid use, as well as some of the negative health outcomes that are associated with it, including opiate use disorder, opiate misuse, and even long-term mortality from all-cause mortality for the individuals who are chronic opioid users. So one of our first steps has been to try to identify opportunities based on the literature to reduce the exposure and the unnecessary or maybe overexposure to opioids for our members who are first-time and non-chronic users. That's part of the first phase of our enhanced opioid strategy, and a lot of these effects and rules went into place in early January of this year, reducing the amount of opioid exposures on the first-time fill, as well as for the total amount of exposure for first-time and non-chronic users, among some other opportunities, including decreasing access or decreasing PA requirements for non-opioid analgesics and other types of initiatives around primary prevention. In terms of secondary prevention, we understand that the chronic user group is a very different type of user group. They have already become dependent oftentimes, or they may be using opioids chronically, and we know that that is a different approach that needs to occur for us to use and to allow them to use to get treatment through behavioral health, primary care, pain management specialists, to allow more supportive care, and something that we've been increasing our outreach through our MCOs. Our MCOs have all been very eager to partner, are looking for opportunities to better outreach and engage with our chronic members and to get them connected to treatment, including opportunities such as voluntary reversible long-acting contraception for women of childbearing age, pain management specialists, behavioral health specialists. But one area in the tertiary prevention and what the rest of the webinar today will focus on, we identify that there continues to be a gap into access for high-quality MAT treatment. It is a necessary tool in the arsenal of addiction treatment and recovery services, and we realized in partnership with our MCOs, our managed care organizations, that we needed to begin to focus on how to increase access to high-quality providers, folks like you that are on the phone that are treating members on the front lines who are struggling with OUD and other misuse of opioids. And so one of the things that we begin to think about is how do we begin to broaden access, provide additional resources and supports on behalf of our MCOs, and to begin to identify and outline those treatment providers that are helping our members lead to recovery, and make sure that we can broaden your reach and to amplify the efforts that you're doing to as many of our members struggling with this as possible. And that's really the third portion of our strategy. As a longer, high-level framework for you to understand how we think about this, the first two steps is really where we're at today. We want to try to identify and standardize some of the basic program requirements that we would expect all of our members to be able to access through recovery treatment services. In addition to that, we really need to focus on how to build a dedicated SUD network that allows for providers who are doing high-quality treatment to have the level of supports and services that match the level of effort to treat their members on the front lines. And so those are really the first two portions of this. But as we build the treatment network through our MCOs and our managed care framework, we believe that it is important to continue to keep an eye on how do we begin to integrate this level of care as not just a pillar or a silo of addiction treatment, but how does this integrate into the overall health of the member and the health journey of the member through care coordination, through clinical integration, and to really support MAT providers and PCPs and behavioral health specialists working as a team, not always in the same location, but across the state as a whole. And ultimately, as we begin to think about the most important thing, which is to improve health outcomes, to reduce the overdose deaths, to reduce the number of individuals with OUD, how do we begin to make sure we're maximizing the value of every dollar we spend in addiction treatment and addiction treatment services. So that's really where we're at in terms of our approach, a lot of work we've been putting in. And so today, our goal is to try to translate for you what our strategy looks like for you as a provider on the front lines. And I'll have pass this over to Sarah to kind of walk us through some of the nuts and bolts from an operational perspective and spend some more time on the specific elements.
Okay, great. So main question everyone came for today is, what do you need to do in order to join this network? So you see there are 6 steps here, and today's webinar is going to walk through all 6 steps and help you guide through the process. So first, we're going to be talking a lot about a program description. For those who registered, you would have received that in email today, and if not, it will be posted to the MCO's website in a couple of days following the webinar. So the program description acts as a guideline for minimum standards for providing MAT. So first step to join the network would be to understand this program description and evaluate your current care model. So that means really looking through it, diving into the model, and seeing what areas you need to improve upon, what areas you already have within your current clinical practice. So that brings us to step number 2, is identifying those gaps that is between your current practice and what the program description outlines. So that may be lack of connections to counseling or lack of care coordination, and where the MCOs could build support for that. Moving on to the third step, all providers must have a Medicaid ID in order to join the MAT network. So we'll talk a little bit about that further in the presentation, about the first steps to begin that process. Step number 4, so once you've gone through the program description, feel that you want to take that next step to potentially become an MAT provider, you will have to indicate interest of this to the MCOs. So on our next slide, we're going to talk about filling out a provider interest form, which will be the first step in signifying to us that this is something you want to do. You can also reach out to the MCO separately, and we have contacts at the end that will be provided. Step number 5, after expressing interest, you will work with the MCOs to potentially contract. Now, contracting is at the discretion of the MCOs, and filling out the interest form, that does not guarantee contracting. This is a process that happens with each of our 3 MCOs. And then lastly, if you do contract, as always, just to continue to provide high-quality care to all 10 care members in the MAT network. So for step number 4, indicating interest, we have developed an online form. So you'll see this top link that says direct link to provider interest form. If you copy that into your web browser, that will bring you to a form that allows you to fill out online. And there's the first question is, are you provider or administrator? So depending on what selection you choose will open a different pathway of questions. The questions will ask you about your, just basic contact information, as well as what BH supports you currently have and what current prescribing practice you're doing. Overall, the survey should take less than 5 minutes, and we'd really appreciate if you fill that out. The information will also be passed on to the MCOs.
Great. Well, let's dive on into some of the program components. As a reminder, we are planning to make sure to answer questions that you all have. If you will submit those through chat at the end of the webinar, we'll be happy to take as many as we have time for and answer any of the ones that we don't get to offline. So the first thing is to describe the program description. First of all, we understand that MAT covers multiple different types of pharmacologic agents. Today, we are focusing only on buprenorphine. The majority of the primary reason for that is we understand that to be a buprenorphine prescriber, there is a different set of regulations, both federally and regulations at the state level, to be an OBOT. And so we want to focus specifically today on the details around buprenorphine. Certainly, we understand there's a place for Vivitrol or naltrexone injectable as part of the MAT spectrum of care, and we have another program description that we will continue to provide through our MCOs around the value and the role of Vivitrol in the overall treatment of members. The most important thing that we want to emphasize is that the decision of which medication MAT to use should be done in a shared decision-making with the patient at the provider-patient level. But today, the goal and the focus of this webinar really is to dive into the buprenorphine world, given the additional layers of requirements and regulations that surround it. So as we discussed, this will be around buprenorphine. The second point I'll make about it is that this program description, while your individual contract will be with the MCO that you choose to contract with or the MCO that chooses to contract with you, it is the same program description across the board for all 3 MCOs. And so we have worked in collaboration and conjunction to try to make this a unified approach given the severity and the gravity of the issues we're dealing with. And so what we go over today should apply to all 3 MCOs, although the ultimate contracting is left up to the MCO to make those decisions, and we'll spend some more time on that later. And the last comment is the sources that we use, we try to pull from the best evidence in the medical literature, as well as some of the leading organizations such as SAMHSA, ASAN, and a lot of the work that's been done in a collaborative fashion across the state of Tennessee. So today, these are the major provider. I think one of the major reasons is why should you contract and why are we making an increased emphasis around MAT? One of the areas we really want to hit is not only to broaden access, but we want to make sure we're providing and allowing ourselves to, at TennCare and the MCOs, to maintain the most appropriate levels of evidence and to be able to wrap our arms around a network that's treating MAT and to be able to support that group of individuals. So identifying as an MAT provider and having a contract to deliver the service allows us to begin to ensure the level of quality and ensure the level of support that's required to be effective in this space. And so that's the first one, is that the MCOs are going to provide additional clinical care and coordination support. Some of you on this on this call are already providing MAT. We understand that, but by identifying and registering as an MAT provider allows you to get increased access to support from the MCOs in terms of resources across the board. The second one is we have really tried to keep attention and pay attention to what the evidence tells us and the different practical implications, and we are open and excited to begin to look at different ways to support through the pharmacy benefit at TennCare some of the evidence-based treatment learnings that we're finding from the front lines. And I'll spend some more time on this in a few minutes as well, around the pharmacy benefits that come with being an identified high-quality MAT provider. The third one is we want to make sure we can provide important and transparent quality information back to you to have a better sense of how your members are doing, how our members are doing across the state, and to look at how MAT is impacting the outcomes that we're all trying to reach together. And by having a dedicated network, it allows us to have more support around the data and the quality. And some of that is related to billing and coding. Some of that is allowing us to be able to use our claims data to provide information back to you as providers on the success and the outcomes of your members. And the last one is by being part of the MAT network, it allows for the MCOs to have a defined reimbursement for MAT services that are in line with the types of efforts and supports you are providing on the front lines as members or as providers. So today in the program description, you'll see that there are 4 major components. There's a treatment element, a treatment protocol and guidelines section, a program component section, and then an outline of how quality of care works. So the first one we'll look at today is the treatment elements. So the treatment elements have 3 major sections: around provider eligibility, around the TennCare pharmacy benefit, and as well as around the general high-level clinical approach for MAT, and then the specific areas of clinical treatment protocols will be in the treatment protocol section. So first, provider eligibility. This is nothing that is new to you all. To be a buprenorphine, again, the focus today is buprenorphine, again, because of these different types of regulations, but the buprenorphine provider eligibility is very much related to some of the federal regulations at the DEA level. So you have to have an under 6 license for the Tennessee Board of Medical Examiners. You also have to have a waiver, a DEA waiver, an X number, as many of you all are familiar with it, that allows you to prescribe buprenorphine. So those 2 things must be in place, and it is important for us to be able to distinguish between buprenorphine providers and Vivitrol providers in this network for us moving forward. Secondarily, the MAT pharmacy benefit outlines in the program description that the formulary that we are using needs to be in line with the TennCare formulary. So the buprenorphine naloxone combination product, as prescribed, should be covered by the TennCare formulary. Secondarily, our TennCare pharmacy benefits manager, which is Magellan RX, pharmacy benefits manager, PBM, outlines procedures and policies to be able to access that through prior authorization. So there are certain criteria that need to be met before a member can receive their buprenorphine naloxone product. And the thirdly is our PBM offers provider support. As I mentioned, the pharmacy benefits that we hope to be able to introduce to members and providers who can join the MAT provider network, we are looking to better decrease any sort of, or to really increase access to the MAT and buprenorphine products as medically indicated, as well as evidence suggests. And so we are looking to have an abbreviated PA form that would allow MAT providers to have a more streamlined process to access the buprenorphine naloxone products. The second thing is we will have a dedicated Magellan call center support system for members that are in the MAT network to really identify and troubleshoot. We understand there is a timing issue oftentimes for members who are beginning induction that need to get access to treatment. We all want to make sure we support high-quality delivery of those services. The third thing is we are looking at opportunities to broaden the formulary to allow for generic buprenorphine naloxone sublingual tablet for members and providers that are in the MAT network, that it will be a change from the current formulary, which is just Bunovel alone at this point. Again, this is a benefit that will be allowed and offered to the MAT provider network. And the third thing is to look, this will be the network with which we will continue to have ongoing dialogue, looking at future opportunities to better align with evidence that comes out as the treatment protocols and the treatment research catches up with some of what's happening on the ground. The timeline for this, as we begin to contract through our MCOs, the MCOs will begin to work with you all, will be to roll this out in a phased approach for members who are contracted in the MAT provider network with full implementation of all these different benefits by January 1st, 2019. So again, these are significant changes from our current, will be a part of our current change. Certainly the remainder of the formulary issues will remain in place, where buprenorphine mono product is available for women who are pregnant and some of the other prior authorization, but for the general public who comes in seeking OUD that doesn't have any of the current existing formulary prior authorization requirements, the goal will be to streamline the process, increase the ease of using the PA to make sure we get the most relevant information, to broaden the formulary to include a buprenorphine naloxone generic sublingual tablet formulation in addition to Bunavail, to increase the arsenal for you on the front line treating members, and to do this over the course of the next several months with a go-live date of January 1st. Those are some of the new pharmacy benefits. Next, I'll talk about the MAT clinical approach. We'll dive more deeply into the treatment protocols, but one of the high-level information is, again, as with everything with opiate use disorder, we are very focused on making sure that members are getting the appropriate education and engagement that is required, and so this includes discussing the risks for overdose, including drug-drug interactions, discussing overdose prevention and reversal agents, including naloxone and other types of antidotes, looking at how and when and having a structured way to discuss discontinuation of medication. Certainly, while abstinence from opioids is desirable, the evidence is very clear that there are several individuals that may require ongoing or even lifelong treatment, and we certainly understand that as a portion and a decision that should be made at the clinical level with the member and the provider. And beneficiaries should be continually assessed for stability. One of the things that we think and believe strongly in is the program description is hoping to outline that the relationship with a member who's undergoing OUD treatment with MAT is an ongoing one that requires multiple conversations, different phases of treatment, different levels of engagement that allows the relationship to mature and ultimately have a way to fully integrate that patient back into their health journey, which includes physical and mental health issues as well, outside of just the OUD treatment. And it is important for us to begin to institutionalize some of these conversations at the provider level. Lastly, some of the supportive measures that we would like to, we've outlined in the program description as well, include education around some additional health benefits that are available through the Tinker program, including access to voluntary reversible long-acting contraception, as well as discussing the therapeutic benefits and adverse effects of treatment medication. That's a high-level overview of the treatment elements. I'll next go to the treatment protocols and the guidelines. As everyone knows who treats members with OUD, they're generally accepted three major phases. The induction phase, which is really the initial startup, medically monitored when you begin buprenorphine treatment, oftentimes occurring in the physician's office, and really to try to help manage those first critical 12 to 24 hours after a patient is coming off of opioids and moving toward buprenorphine naloxone, and to look at how to manage some of the symptoms that occur in that. The second phase is the stabilization phase, which begins after a member has discontinued the drug, but have now maybe needing to titrate their dosage to reach a level that is physiologically appropriate for them, that allows them to maintain, to minimize any opioid withdrawals, to maximize their chances of success, and ultimately moving into the maintenance phase. The maintenance phase can last for a long time, as we just discussed, but we have, in our program description, broken that into maintenance phase for under a year and maintenance phase for greater than a year, and you'll hear us refer to that going forward. This is a high-level overview. Again, we will make sure that these slides and the webinar, which is recorded, will be posted. So, and this is also outlined in your program description. So if you are following along, we'll make sure you have access to this at the end of the webinar. But wanted to, at a high level, let you see the differences and the types of expectations around how to engage the member. We took this a lot from the ASAM/SAMHSA guidelines and speaking with providers on the front line. We took lots of input and tried to outline what we hope will allow you to maximize your efforts and to maximize the supports and services you're delivering to members. So in terms of office visits, the induction or stabilization phase, the general guidelines suggest that that should occur weekly. And the maintenance phase of treatment for less than 1 year, every 2 to 4 weeks. And then in the maintenance phase, if they continue over a year, every 2 months. That is just a general guideline for the level of treatment. There may be instances where a member who's doing very well may need a little bit less than that, and other instances where a member who in the early phases may need to have much more close supports and social supports and counseling, who may need to come in more frequently. But this is at least a minimum of what we are looking for in order to support the continued delivery of services to our members. Secondarily, we understand that counseling sessions do play an important role. Certainly the evidence is continuing to be studied about the types of counseling, the types of peer recovery support, the types of behavioral health counseling. Those are all important pieces of the literature we'll continue to follow along. But it is important for us to have offerings and to have members to be able to have access to counseling services if that's the best decision for them, at least twice a month in the early induction or stabilization phases, at least monthly in the maintenance phase for less than 1 year, and at least monthly after 1 year unless clinically stable with continued signs of recovery. Thirdly, drug screens are an important portion of this as well. It is important to have accountability and to have high-quality treatment that allows for accountability in the relationship. And so we will make sure we have outlined some drug protocol, screening protocol in the program description, which you will likely will want to spend some time reading as well. In the early induction or stabilization phase, as part of the accountability and support to make sure the member understands and to begin to grasp the journey they're on, we are looking for observed drug screens at least 1 time weekly. Over the year, in the first year, at least 8 times through random samples, and then at least 4 times annually if they continue to stay on maintenance for greater than 1 year. And lastly, care coordination services, which is a fourth and really important component. The literature suggests that care coordination is one of the driving factors in helping members maintain and stay in recovery. And so we want to make sure that care coordination services are either offered directly through your offices or in conjunction with the MCO if you don't have those types of resources, and at a very frequent basis of weekly if it's the first induction or stabilization phase, monthly if it's in the maintenance phase less than 1 year, and ongoing monthly as indicated for those who are greater than 1 year. In terms of drug screen protocol, here's some more detail on it. I won't spend time reading each of these individual portions. We encourage you to look at the protocols as listed in the description. Again, this is based on several different national consensus guidelines around how you should collect and test, how you should define a positive test, how you have a conversation with a member, and as how the documentation and follow-up of this will occur. I encourage you to read that as a separate section, just highlighting that that's a different section within the treatment protocols and guidelines. In the third section of the program description now, I'll spend some time talking about the program components. So care coordination, as we mentioned, is a large portion of this, as well as behavioral health services. And so our MCOs are ready and are eager to support and identify who within your office might be serving as a care coordination resource. And if you don't have that type of a care coordination resource, the MCO will be able to point you to other individuals, or they themselves may be able to provide support services for members who are high risk that need care coordination services. Really the value is to highlight and have this ready at the beginning of when a member begins induction. And so we encourage you to have those conversations to evaluate what types of resources you have on the care coordination in terms of making sure that travel arrangements may be appropriate, or scheduling the appointments, following up, how to support the family members with education, those types of services that fall outside the traditional direct care delivery model. How does that fit into your care model? And if you have questions or concerns about how that occurs, our MCO provider reps will be happy to have further discussions with you. The second area, which I will have Mary talk much more in depth about on the behavioral health, is around how to make sure that behavioral health is offered at the beginning for members who may benefit from that. Again, peer recovery support services and behavioral health services are in the literature beginning to show some benefit when done in conjunction, and so we want to make sure that those services are offered appropriately. I'll turn over to Mary to talk about this more in depth.
Thanks, Dr. Wu. I wanted to highlight this item in the program description and clarify the intent. As Dr. Wu said, TennCare and the MCOs view counseling as an important component within MAT. We also know that each member has their own personal recovery path. For some members, they may reach a point in their recovery when counseling is no longer clinically indicated. With that, while counseling is a recommended component of MAT, a member may continue to receive prescribed buprenorphine even if not participating in the counseling. The MCOs also want to be a resource for providers who need to refer their members in a MAT to professionals who provide counseling services. The managed care organizations want to offer this assistance and connect to counseling services as needed. So we see the phone numbers right here, and those are also listed in the MAT program description. So if you are a provider prescribing buprenorphine and you do not have counseling services available at your location and you're needing help finding a provider for your members, you may call one of these phone numbers depending on the member's MCO, and the MCO will help locate a provider for you. So to round out the program components, there are sections on patient accountability and supportive activities. I wanted to highlight the engagement with the certified peer support or peer recovery specialist. That's the last bullet under supportive activities. The intent here is to ensure the peer recovery specialist services are available to members who want and or would benefit from these services. Each MAT provider does not have to employ a peer recovery specialist, but there needs to be a path for referral to an agency or to a peer recovery specialist who can provide these services. We have attended several conferences and webinars over the past year on the treatment of opioid use disorder, and we have heard that the outcomes for MAT engagement are much improved when coupled with the peer recovery services.
The last section of the program description outlines quality of care and how the MCOs and TennCare hope to support making sure that the quality of care that you're providing is accurately reflected and scaled across the state. The goal really is to allow our providers to work collaboratively with their MCOs to assess the quality of care they're providing to the members. Part of the process of how we'll assess the quality of care is really to allow for on-site support, individualized to your practices from our MCOs and their provider representatives. And we'll, as part of the assessment, is really to look at the medical records, to look at program standards and requirements, how and if there are any gaps that need to be filled, as well as the clinical treatment guidelines, how those are being applied on the frontline level. A key component of this as well is to make sure we have an opportunity to assess member experience through your experiences on the front line to allow us to begin to continue to support and change or morph the program description as needed to make sure that the member is maximizing their chance at recovery. And so the quality of care assessment will be part of the process that our MCOs will use, both in terms of the initial and ongoing support that they provide once a provider has joined the MAT network. Secondly, there will be a portion around the quality review. So this is much more of a quality metric component that allows for transparency around health outcomes for your members. And we are going to be using different measures that have been validated or claims-made measured, as well as looking at opportunities to tailor some of the metrics around our care being delivered here in Tennessee. The 5 domains that we hope to focus on that will allow some transparency around the delivery of care services for your practice, as well as the focus on the outcomes that occur for our members receiving OUD treatment through your practices are really across these 5 domains. The first one is around length of MAT treatment, how many days of continuous treatment the member remains in treatment. We know the evidence and literature shows that the longer and more continuous they are receiving MAT, the more likely they are to maintain recovery. The second one is the use of behavioral health services during MAT. It continues to be an important part of the program, but we want to understand the impact and the outcomes that result from the members who are using behavioral services. The third thing is looking at your drug screen frequency, again, as that portion of accountability and oversight. The first one is to begin to understand healthcare utilization patterns of our MAT providers, so looking at emergency room visits, hospitalizations, trying to provide data that you as an MAT provider may not otherwise have had access to in the past. We want to begin to increase the transparency around that as you begin to embark on this journey of ensuring and having accountability around the quality of care. And the last one is to look at some risky behaviors that could occur, such as concurrent use of benzodiazepines and or opioids while on MAT. We understand that the state buprenorphine guidelines allow for a tapering period of time for the benzodiazepines, and we certainly will account for those types of items in the quality metrics, but overall we want to continue to see support for our members recovering from substances, including opioids and benzodiazepines. So that takes us through the rest of the program description, each of the 4 components. We certainly anticipate that there may be questions that will arise, and we will happy to field those after you have some time to digest. Our MCOs and their provider reps will be able to use this as part of the contracting process to, again, have that discussion with you in the office or on the phone as you begin to signal interest about how and if there are gaps. But we are hopeful that this can continue to be an ongoing dialogue as we continue to grow the MAT program. Again, this is for buprenorphine. I'll highlight one more time that there is naltrexone. For those of you providers that are performing naltrexone either in conjunction with buprenorphine or individually and just as a naltrexone provider, there is a naltrexone protocol that is very similar, has all the same components, has similar outlines, which we will share as well at the conclusion in the upcoming days as you begin to signal interest. And certainly we understand that there's a role for ongoing care coordination services between buprenorphine and for those of you who are looking at how to transition sometimes from buprenorphine to Vivitrol or to naltrexone injectable, and we're open to those discussions as well. But today the focus of this webinar is to really identify discretely between buprenorphine and at a future time between naltrexone for further discussion. I'll give it to Sarah again to kind of talk about some of the more nuts and bolts and administrative portions of how we begin the process again.
All right, so back to the slide that we saw in the beginning. For step 1, we just ran through overview of the program description. Again, still recommend going back, reading that, really absorbing that, and digesting that material. Number 2, that's going to be where you take the reflective part and go back and really, again, figure out where your gaps of care exist. What we're going to focus on right now are step 3 and step 4. So first, for step 3, that's obtaining that Medicaid ID. If you don't already have one, it is essential to have one. So I'm going to move on to the next slide. Here, this is the basic first steps to getting a Medicaid ID if you do not have one. The link at the top of the page is the main landing page where it gives you all the instructions on how to start this registration process. It will give you 2 options, so either registering as an individual provider or as a group provider. So an individual provider would be like Dr. Joe, a sole practitioner, whereas a group provider would be, for example, Happy Valley Pediatric Group. So choose which one fits your registration process and start there. TennCare will then validate that ID and send that back to you so you can start the contracting process. All right. And then back to step 4, this is how to indicate interest in becoming an MAT provider. Again, just remind you to fill out that form. The direct link is at the top of the page, and if you misplace this link, it is also located on our opioid strategy website page, and that link's at the bottom of the screen. It should only take about 5 minutes, and this will start the indication of interest.
This is Mary. And moving on down the process here, step 5 would be to contract or recontract as an MAT provider with the appropriate MCO to join the network. As many of you know, TennCare is 100% managed care, meaning TennCare as the state Medicaid agency contracts with 3 managed care organizations. Each MCO is responsible for contracting and maintaining their own provider network. So there's 3 components to provider contracting: the MCO contracting and oversight, the provider completing the CAQH process for the provider registration with TennCare, and then ensuring that either the individual provider or the agency has the appropriate license. So representatives from each MCO have joined us for this webinar, and over the next several slides, they will share their contact information for those providers who are interested in contracting for MAT services, as well as giving a brief overview of their contracting process. So first up, we have Blue Care. Melissa, are you on the line?
And give us 1 minute. We'll have to do a little bit of technical maneuvering to allow our MCO representatives to go ahead and speak. I would ask you all that to make sure to make your line muted to allow for our MCOs representatives to give their comments. Give me 1 second to switch over and open up the line for our MCO representatives.
Yes.
I would ask you all please to mute your lines so that we can allow for our Blue Care representative to begin speaking.
Hi, it's Melissa. Can you hear me okay?
Yes, Melissa, this is Mary. We can hear you. And then just a reminder, we've unmuted everybody's line, so please mute your line. Thank you. Go ahead, Melissa.
Thank you. So I'm not seeing the slide now, but you did get a quick peek at the slide that contains the contact information that we will have available for this initiative. I am Manager Behavioral Health Network Strategy and Innovation, and I've been working collaboratively with our groups internally to put together a buprenorphine MAT network development initiative. And what we are looking to roll out will be some unique coding and reimbursement constructs around the induction and the maintenance phases. We'll be using 3 different codes. There's an induction code, there's a maintenance code with counseling, and there's a maintenance code without counseling, which hopefully that will kind of make sense in the context of the information you've received throughout the presentation. So our first phase of this campaign will be specific to the current in-network prescribers that we have been able to identify and verify as holding the SAMHSA waiver in our networks. It's not a perfect list, as you might imagine. We've put that together from multiple sources. Sometimes those sources that we were using didn't have any actual unique identifying information, such as NPIs. So we're working with what we have, but we do have our facets information, our internal provider data information on those providers that we've identified. And we'll be using that to push out amendments by notification in July. So, recognizing that our demographic information might not quite align with a prescriber's MAC practice, especially if they're separating their primary specialty practice from their MAC practice, it's always a good idea if you want to outreach us, either using the provider interest form information that Sarah shared, or by using the contact information that we've provided in this webinar event, so that we can make sure that we've got the right information, because if we don't get any updated information from you, our contract packet information will go out to the information that we have on file associated with your in-network record with us. So just wanted to kind of explain that. So again, we'll expect to roll out that amendment by notification to that campaign list of in-network providers in July, and we'll be asking those prescribers to complete and return an attestation page and a checklist that will be in that packet. And we'll be using that information to actually load those prescribers as our buprenorphine MAT prescribers in our MAT network. So it's really important that we get that information back, because we want to make sure that we've got the right location information and all the appropriate demographic information for your MAT practice. And that will help us make sure that our members are able to get to you at the right location. Very closely on the heels of rolling that information out to our in-network providers, we will turn our attention to other providers who are not in our network who need to be credentialed and contracted as new prescribers. And we'll be focusing those efforts on our greatest access and availability capacity needs based on what we've been able to build out from our in-network providers. So we'll get you on the list, we'll look at where you're located, those kinds of things, and then we'll work through the process of getting those prescribers credentialed and contracted. A couple of things to know, as Sarah mentioned earlier, really important that you have a Medicaid provider ID. For Blue Care, we also use CAQH for credentialing, so you'll want to make sure that you've got a CAQH profile, that it's up to date, and that you have authorized Blue Cross Blue Shield to access that information for credentialing purposes.
Okay, thank you, Melissa. Next, we have Philip Morrison from Amerigroup.
Thanks, Mary. Can you hear me?
I can hear you. Thank you.
Okay. All right. We're going to be rolling out a similar type of process as Blue Care and the other MCOs. As far as credentialing goes, we do utilize CAQH. We're going to be taking a little bit different approach, as with all of our new providers, our current providers will be reaching out to you. Your current provider relations representative in each region will be in contact shortly after these webinars to get that process going. As far as any new providers that are coming into the network, we do ask that they contact our internal provider relations team. The reason for this is our reps are out in the network or out in the field quite a bit, so we want to make sure that these calls are answered in a timely manner. They're also, with our internal team, they will be tracked and documented to make sure that, we don't lose any in the meantime. So, again, we've already begun the process. We've spoken to several new providers and existing providers across the state in the last couple of months, and we will be reaching back out to finalize the contracting process.
Great. Thank you, Philip. And next we have Victoria White from United Healthcare. Victoria?
Good afternoon, everyone. So we're following actually the same kind of process that Blues and AmeriGroup is following. We're going to be working on 2 different subsets of providers, existing providers and new to our network providers. So those providers that are new to our network will need to complete a request to contract. Our contracting staff will then reach out to these new providers with a credentialing application. All providers, regardless of whether they're new to our MAT network or they're existing providers, will receive outreach to review the MAT program description. We really want to make sure that everyone understands the program expectations and be available to answer any questions that might arise. During this time, we will also be gathering some additional information from each provider for review by our clinical staff, and this is really going to be specific to the items outlined below there related to policies and procedures, staffing, the written plan for addressing specific clinical situations, confirmation on whether or not the medication is dispensed on site or if the member is receiving their medication through a local pharmacy, and then written processes or plans on how the provider will conduct assessment of the member experience. If anybody has any questions, please do not hesitate to reach out to any member of my team. We're happy to answer any questions that you might have.
Great. Thank you so much, Victoria, Philip, and Melissa. We appreciate you being on this call. So we have a few additional slides on resources. The resources that we have in this deck are also the ones that are listed in the program description at the end of the document. And if you haven't had a chance to go to the SAMHSA website or the ASAM website or read through the Tennessee Non-Residential Buprenorphine Treatment Guidelines or the other resources we have, we do encourage you to visit these websites and do some additional reading. A good part of our program description was just copied, and we used a lot of their information to build the program description. So as we shared just a few minutes ago, here's the contact information for Blue Care, AmeriGroup, and United Healthcare. All contracting questions need to go straight to one of the managed care organizations. If you have a question specifically about TennCare's buprenorphine MAT program, you may contact me and I will get the information back to somebody here at TennCare to answer the question and get a reply back to you.